Thank you, John Felix. Abisola Lakoja. Adeleke Benga, Adeyemi Mojid. Thank you. Basirat Hamid. Ayomiku Koka joined us pretty early. Thank you. Dora Eze, Ebube Inwigwe. Ekpeyong Ndueson. Sorry if I can't pronounce that well. Thank you so much for joining us so early. Elizabeth Adioshun. Thank you, madam. Hassan Adijat Titilayo. Thank you for joining us. Judith Ifoma. Stella Mba. Yes, from Junior Grammar School, Surulere. Thank you very much, Madam Stella. We're doing this in honor of teachers, and we're glad to see that you are a teacher joining us this morning. Gospel Egeruan, Hassan Adijat Titilayo, Idris Moshud, thank you all for joining us. We have 1 more minute to start. Yes, Oladoku Yusuf, thank you so much. Testimony Ayesa, thank you. Yeah, we believe that many people will join us as we progress. Yes, Elizabeth Adioshun. Thank you, madam. Thank you so much. Okay. Dr. Onjefu, we're very grateful. Thank you for taking our time to do this with us. Thank you so much, sir. Okay, it's 10 a.m. and we will start the program. Thank you very much, everyone around the call. Thank you to our trustees around the call. Thank you, a big thank you to our guest speaker of the day, and a special shout out to all teachers and everyone who is in the education sector around the call this morning. On behalf of the chairman of the Board of Trustees of Rehoboth Dream Solid Foundation, Sir Oladende Olusoga Joseph, CON, MNI, former governor of Ogun State, and other distinguished trustees of the foundation, I welcome you all to this webinar today. A little background to the webinar. We do this periodically. We host workshops and webinars on various topics. Some of these trainings are followed up by classes sponsored by the foundation just to enhance the skills of the participants. The workshops in the last quarter of the year, however, are planned to coincide with the annual Teachers Excellence Award organized by the foundation to celebrate teachers that have exhibited excellence in the discharge of their duties. So this specific webinar, in addition to helping us empower our mentees, is also dedicated to teachers who we are very proud of. Today's webinar is our 10th, and the topic is breast cancer in the Sub-Saharan Africa, our peculiarities and challenges. We have the recordings of past editions of these webinars on our YouTube channel, which is also the name of the foundation. So if you go to YouTube and you look for Rehoboth Dream Solid Foundation, you would see recordings of past webinars that we have held. We will not take too much of your time today. We want Dr. Onjefu to help us demystify breast cancer and help us understand how, what we can do as men and women to defeat the menace of breast cancer. We would have a question and answer session after he speaks, and then there'll be a wrap up. So we're not going to take unnecessary time. Dr. Onjefu, it's a privilege to have him. He has written for the quarterly magazine of the foundation in the past. For the articles that he has shared with our readers, we are very, very grateful. He's a very busy man, and so we are privileged to have him today. He is a senior registrar in general surgery in the University of Ilorin Teaching Hospital. So he comes speaking from a position of authority. Thank you very much, sir. The floor is yours now. You can share your slides and start your presentation, sir. Thank you very much.
Thank you very much, Ma, and thank you, everybody. As introduced, I'm Onjefu. and I am speaking from Ilorin, in north central part of Nigeria. We are discussing breast cancer in the Sub-Saharan Africa, our peculiarities and challenges. Follow this outline in our discussion. The aim of the discussion will not be academical, so academic details may not be emphasized on, but a call to action. Everybody, anywhere we are, to do something about breast cancer, especially in the Sub-Saharan Africa. If at the end of the meeting, and you're a female, you examine your breast, you have done something. If you are male or female, you speak to your wife, you speak to your family, you speak to your mother about breast cancer, you have done something. But at the end, everybody should do something. Breast cancer has become a global problem. In the past, it was thought that breast cancer was a problem of the developed nations. But today, more than 50% of breast cancer burden is found in the developing countries. It is of particular public health importance in the Sub-Saharan Africa because of some peculiarities and the challenges we face in the management of breast cancer in this region. Though the incidence of breast cancer is low in Sub-Saharan Africa, the mortality is higher than any other place in the whole world. It is the most dreaded disease of the breast, meaning that it is not the only disease that you can find in the breast. But none of the other diseases are of public health importance. If left untreated, breast cancer will surely kill, but it kills slowly in a very distressing way. The trend in the Sub-Saharan Africa can be reversed as it was done in the developed countries, especially in the United States. Every 15 seconds that tick, somebody somewhere is being diagnosed of breast cancer in the world. And every minute, somebody somewhere dies from breast cancer. It is the commonest cancer worldwide. In Sub-Saharan Africa, it is not only the commonest cancer, it is the commonest cause of cancer death. Today, worldwide, more than 2.3 million are diagnosed every year, and more than 685,000 women die from breast cancer every year. And the incidence is on the increase. And it has been projected that by the year 2040, the incidence will double and the mortality will also double. Though in the world, Sub-Saharan Africa is one of the least in terms of incidence of breast cancer. But in the past 10 to 15 years, it has been on a steady increase that ranges between 3 to 5% per year in this region. Compared with what is happening in the United States, that is just about 0.5. That means in terms of increase in incidence, it is increasing in Sub-Saharan Africa than the developed nations. In 2020, about 190,000 cases of breast cancer were diagnosed. And it has been projected that this will double in Sub-Saharan Africa in the year 2040. And by the year 2050, the majority of breast cancer and majority of breast cancer deaths will be from the Sub-Saharan Africa. There is a serious disproportionate between the incident rate in Sub-Saharan Africa and the mortality rate. Even though people in the developed nations have more breast cancer than people in the Sub-Saharan Africa. People in Sub-Saharan Africa die from breast cancer more than people in the developed nation. And West Africa in particular has the highest mortality rate in the whole world. Just for the purpose of description, this looks like the normal female breast. But I'm not interested in detailed anatomy. I want you to know that the breast, apart from being a figure of cosmesis, has cells that produce milk for the newborn. Apart from those cells, there are some other structures within the breast parenchyma. We have fat tissue, but every other structures there, the cancers that develop from them are just less than 10%. The cancer that is a problem that we call breast cancer worldwide are the ones that develop from the lobules, where breast milk are produced, and the ducts that conduct the breast milk to the nipple. Now, along the ducts, there is the lining of cells, single layer. When the breast cancer starts, usually it starts from there. When it starts from there and has not gone beyond that one layer of cell, it is called cancer in situ. Good thing about that, and the reason why I'm bringing that out, is at that earliest stage of breast cancer, even the smallest imaging modality we have all over the world can pick it. Mammography can pick it, ultrasound can pick it. But that is the earliest stage. And if it is picked and treated at that stage, cure is expected to be 100%, and the patient is expected to live normal life. Fortunately, in places like United States, about 70% of their patients are picked in the early stage, unlike in the Sub-Saharan Africa, that more than 80% are picked in the late stage. The late stage are the stages 4. I will come back to that. Histologically, breast cancer is classified into in situ carcinoma and invasive. If it is limited to the epithelial lining, that single cell layer on the dot, it is called in situ. If it breaches that, it is called invasive. The in situ, since I started, in fact, in the last 5 to 7 years in our center, I have seen only one. Meanwhile, that accounts for the highest in the developed nations. Now, apart from the histological type, there are molecular subtypes of breast cancer. There's the lumina A, the lumina B, the basal-like, and the HER2 enriched. The lumina A has the most favorable outcome. The response is good. The lumina B has good response, but a bit poorer prognosis than lumina A. The basal-like, which is also called the triple negative, has the worst prognosis. The HER2 enriched used to be the one with the worst prognosis until the discovery of targeted therapy, because that subtype is very, very sensitive to targeted therapy. But targeted therapy is very, very expensive that an average patient in the Sub-Saharan Africa cannot afford. Later, I will show in part of our peculiarities that the most favorable subtype is commonly found in the Western nations. The ones with worse prognosis are higher in the Sub-Saharan Africa. People keep asking, what is the cause, or what are the things that cause breast cancer? Honestly, the causes of breast cancer are not fully known. It is suggested that there is an interplay between the genetic makeup of a patient and the environment or the lifestyle the patient chooses. But we know that there are certain factors that are associated with development of breast cancer, the risk factors. Sex, the most important risk factor. That a person is a woman is a risk factor. Age, breast cancer is not seen before puberty. But as a woman ages, the risk of developing breast cancer becomes higher and higher. Again, I am going to show us later, while it is commoner above 60 in developed nations, in Sub-Saharan Africa, more than half of our patients present before the age of 50. Genetic makeup, family history are other risk factors. If you look at all these ones that I have mentioned, menarche, early menarche, late menopause, they are not things that you can change. They are things that came to you without your doing. They are non-modifiable. But there are some things that are modifiable that, if worked upon, can reduce the chances of developing breast cancer. Some of those risk factors are the ones I mentioned there: obesity, physical inactivities, consumption of alcohol, smoking, and some other things. Most times, breast cancer does not show any symptom in the early stage. But the most constant symptom of breast cancer is a lump. When a patient or a woman comes and says, I notice a lump in my breasts, in most cases, they are not painful, which is one of the big problems we have in the Sub-Saharan Africa. Because it is not painful, patients will tell you that it doesn't pain me, it doesn't stop me, I go about my business. By the time breast cancer begins to pain, in most cases, it has gone beyond the cure, when little or nothing can be done. Other ways it can manifest is a discharge from the nipple that may be bloody, that may look like water, or any other color, and so many other ways. Once there is a change in the outlook of the breast of a woman, the wisest thing to do is to look out for breast cancer. How is the diagnosis made? In academic or clinic world, we use triple assessment, meaning that we physically examine, then we use imaging, ultrasound, and mammography. In fact, mammography is one of the instruments used to reduce the mortality of breast cancer in developed nations. And it's available, and it's not too expensive. Ultrasound is used for younger patients, while mammography is used in patients above 50. The third in the triple assessment is biopsy. That one is done by a clinician, not any other person. Breast cancer is staged from 0 to 4, and the commonest staging for clinical use is the American Joint Committee on Cancer, stages 1 to 0. When it is limited to that one layer of the epithelium lining the dot, and it has not gone beyond that, the earliest stage is tagged stage 0. But when it has gone beyond the breast, the armpit, or the axilla, and has gone to a distant place in the body, it is stage 4. Commonest places that breast cancer metastasizes to are the brain, the bone, the liver, and the lungs. If it is stages 0 to 2, it is referred to as early. And if you are managing that, your aim is to cure. If it is stages 3 or 4, it is advanced. The aim of management is to palliate. That palliation, you make life comfortable for the patient. You can extend the life, but you no longer aim at a cure in most cases. But in Sub-Saharan Africa, it's like more of a death sentence. Treatment, several modalities of treatment. Surgery, which may be a total mastectomy, in which case the whole breast is removed together with the cancer. The world is shying away from that now because an average woman wants to retain her breasts. Or a surgery that is called breast conserving. In that case, you retain the breast for the patient, or you take the cancer out with the surrounding normal tissue. But as a rule, if you will do a breast conserving surgery, the patient must have radiotherapy. If you don't give the patient radiotherapy after breast conservation, the chances that breast cancer will recur is almost 100%. Another option is radiotherapy, as I've mentioned. Then, in addition to that, there are medical therapies, chemotherapy, targeted therapy, or hormonal therapy. One of the things that determines which medical therapy a patient will benefit from is when you make your tissue diagnosis by biopsy and you have the immunohistochemistry. The patients that have a hormone receptor positive, they'll benefit from hormonal therapy. People that are HER2 positive, they'll benefit from targeted therapy. The triple negative, the only option in addition to surgery and radiotherapy is chemotherapy. Triple negative, which is commoner in Sub-Saharan Africa, does not respond to targeted therapy. It does not respond to hormonal therapy. What's the prognosis of breast cancer? It's good if the presentation is early and the management is appropriate. It is poor usually when the presentation is late or the treatment is suboptimal. But is breast cancer, does breast cancer have good prognosis in Sub-Saharan Africa? It's a question that if you manage breast cancer, will not be difficult for you to answer. 5-year survival of breast cancer management overall in the United States is 90, meaning that when you manage a patient, 100 patients with breast cancer in the United States, in the next 5 years, you still see 90 of them walking on the street. Unlike in the Sub-Saharan Africa, where the 5-year survivor is less than 40 in most areas of Sub-Saharan Africa, more or less a death sentence. 100 patients with breast cancer treated in 2023, by 2028, 70 of them would have died. So is the prognosis good in Sub-Saharan Africa? Why? Because if you are following me, the question why would have filled your heart. Why is it that they survive well in the developed nation and they survive poorly in our place? Why is it that we have all of this and they don't have it in the developed nations? The answer to that question is our peculiarities and our challenges. Number one, patients in Sub-Saharan Africa, they present earlier in terms of age than patients in developed countries. About 60% of our patients are women below the age of 50. Unlike in developed nations, where more than 60% of their patients are above the age of 60. So younger patients in the Sub-Saharan Africa, older patients in the developed nations. And when breast cancer occurs in a younger patient, it has a worse prognosis, it is more aggressive and less responsive to treatment. So it's our peculiarity. It is not what we have used our hands to cause. Number two, breast cancer is graded 1, 2, 3. The grade 1, they are low grade. Grade 3, high grade. The low grade are not aggressive. The high grades are very, very aggressive. When a low grade is diagnosed today in early stage, in the next 2 years, you can still treat very successfully. But when the high grade tumor is diagnosed today, in the next 2 years, if care is not taken, the patient would have gone. In Sub-Saharan Africa, 68% of the breast cancer in our people are high grade. Unlike in developed nations, where only 29% of the cancers in their patients are high grade. Others are either low grade or moderately differentiated. It has been speculated, though we have contradictory studies, that genetic mutation is higher in the Sub-Saharan Africa, but that assertion has not been well established. Now, I have mentioned the molecular subtype. There is a strong disparity between the molecular subtypes that occur in the Sub-Saharan Africa than the ones that occur in the developed nations. Look at Uganda, one of our countries. The Lumina A that I say has the best prognosis, best response of all the subtypes, account for 39% in Sub-Saharan Africa. If you look at Lumina A in the United States, it's about 70%. So naturally, breast cancer in the white has better or favorable prognosis than that which occur in the Sub-Saharan Africa. Now, I mentioned that HER2 rich has a very bad prognosis until the discovery of targeted therapy, which is not affordable by most of our patients. In fact, in the last 5 years, in our own clinic here, I have only seen 2 patients that completed their targeted therapy. One was a doctor, and our association has to raise money for her because she needed like 50 million to complete it. The second person has a brother in the United States, has a brother in the US. They were the one that sponsored it. I've not seen any other person that was able to buy that. Now look at that HER2 enrich is only 4% in the United States. Look at it in Africa. It accounts for 22%. Look at triple negative that has the worst prognosis. It accounts for 34% in Sub-Saharan Africa, and it only accounts for 10% in developed countries. These are some of the peculiarities we have. We met them. It's not our cause. In addition to these peculiarities, we have our own challenges that we can actually work on and reverse the trend of breast cancer. One of it, and the worst of them, is the late presentation. In developed countries, about 15% of their patients present in late stage. That is stages 3 and 4. In our own case, in Sub-Saharan Africa, more than 80% of our patients present in late stage. So about 85% of patients in developed countries present with early stage. That anywhere you are, the aim of management is cure. Unlike our own people, that 80% will come in a late stage. We had a study here recently that within 1 year in our clinic, about 136 patients present in emergency. The meaning of that is that 1 year, 136 people came presented to emergency with metastasis. That you hardly, in fact, a study was done in the United States. Most of the patients that come with advanced stage, out of that 15%, most of them are immigrants. They came from outside the United States. So what is the reason for late presentation in Sub-Saharan Africa? Some people say it's lack of awareness. Of course, yes. That is seriously responsible for late presentation. But is that really the reason? A study was done recently in our hospital, and we discovered that both the educated and non-educated put together, about 90% were aware of breast cancer, though the educated ones have better knowledge of breast cancer, but all of them, literate and illiterate, they were aware of breast cancer. So in those days, we kept clamoring awareness, awareness. But even now, that a high proportion of our people are aware, it does not change the late presentation. 2022, we did a study in our own hospital. Still, 86% of our patients present in advanced stage. So when we are saying that presentation is late, we are not talking of a distant past. Even today, presentation is still late. So another thing that makes our people present late is the fear of treatment. They are aware of the fact that treatment has a lot of side effects, chemotherapy, surgery. You are not sure whether you will survive surgery, or you tell a patient, I'm going to remove your breast, which an average human will want to retain. So the fear of surgery also keep many of them from presenting early. Now, a study was done here in 2021. About 60% of the patients that present with late or advanced stage of breast cancer actually discovered the cancer early. They became aware of the symptoms early. But the lag, the time between the time they became aware and the time diagnosis was made and the time treatment was commenced was so long. A study was done. So many studies have been reported from Kenya, Uganda, Ghana, and Nigeria, that the average time a patient in Sub-Saharan Africa will have her diagnosis made histologically from the time he first became aware of the symptoms is about 14 months, which is too long. Now, a study recently in Ilorin here also showed that apart from the fact that the patients themselves, they come late, before they actually see a specialist to have their diagnosis made or commence treatment, they would have seen an average of 3 or 4 health professionals. But the status of those professionals, I don't know. Some of them are pharmacists, some of them are nurses, some of them are auxiliary. In fact, some of them are hospital workers that are non-clinicals. About 40% of our patients would have received antibiotics for breast cancer before they come. Antibiotics has got nothing to do with breast cancer. So there is a prolonged time between the awareness of symptoms and the time commencement of treatment is done in Sub-Saharan Africa. Another challenge is the acceptance of treatment. Sociocultural factors are a problem in this part of the world. A patient is made aware and has been told the diagnosis of breast cancer, will she accept the treatment? If she does not, there's no difference between that patient and the one that does not even come at all. But it's a big problem here that by the time you tell a patient, this is the diagnosis, about 60 to 70% of our patients will decline the diagnosis. Some will say, I reject it. And we discover that this thing is seriously influenced by their religious belief, both Muslims and Christians alike. It is a common thing in our own setting here that a woman will come, maybe because in the church or in their mosque, a campaign, awareness has been made, and she discovered there is something in the breast. He came and we made the diagnosis. And the diagnosis is early stage breast cancer. And we say, wow, this is a good news, even though there's nothing good about breast cancer. Our aim is a cure. And the patient will only tell you, I reject it. And the next time you will see her is 2 years' time. When she comes, the cancer has gone to the brain, has gone to the lungs, has gone to the bone. She cannot walk. At that time, she wants to accept your treatment. But at that time, with what is available to us, only little or nothing can be done. Cultural beliefs. It is commonly believed in our environment. A patient told me when I told her about breast cancer that with this stage and with the available instruments we have, you will need chemotherapy. And we will need to operate and remove the breast. He said, look, I will come back to this life again. Do you understand what they call reincarnation? I say, yes. He said, I will reincarnate. If I don't die with my breast, I will come back without a breast. Cultural belief. And he left. And so it will take us a lot of time to convince our people to accept the available treatment we have. But we cannot blame them too much, because if it were in advanced countries, some of the treatment we offer them, they will not even have needed it. The patient that comes in with early stage, of course, worldwide, the treatment should have been a breast conserving surgery. But as a rule, like I told you, the patient must have a radiotherapy. I'll come back to it later. That because we don't have radiotherapy readily available in Nigeria, most of our surgeries are not breast conserving surgery. Most of our surgeries are mastectomy, the removal of the total breast. A study was done involving Nigeria, Ghana, and Kenya, only to discover that about 80% of our breast surgeries are mastectomy. Only 20% are breast conserving surgery. Now, this acceptance of treatment, does education help? Because one of the things we are going to be talking about as one of our way forward is education. Again, it helps because we have discovered from studies that were done in Sub-Saharan Africa that most of the patients that present in early stage are patients with education above secondary level. So education influences the stage at which our patient present. But we have also discovered that both the educated and non-educated alike decline management. A 25-year-old fresh graduate was diagnosed. It was a single lady of breast cancer. The mother was a chief nursing officer in a teaching hospital. And we said, it's early, so we aim at a cure. The mother, the patient, a graduate, but they decline treatment, that it is not their portion. Every detailed explanation was made to the mother and the patient. They declined it. But less than 18 months after the diagnosis was made, she came back with metastasis to the breast and brain. Of course, she died. So if education actually helps, at least a health professional should not have done what the chief nursing officer. So we agree that education a study was published as stipulated by the doctor were due to financial constraints. A doctor from Kenya, it's not only in Nigeria, told a story bitterly of a patient he was managing. He gave the first and second courses of chemotherapy. And this woman had a very good response, and the doctor was happy. Only for her to discover that the patient disappeared. 6 months after, the patient came back rejoicing that she has gotten money for the next course. Of course, even that cancer will not respond to that regimen of chemotherapy again. Financial constraint. Most of our people don't have the money because the management of breast cancer is expensive. Chemotherapy is expensive. Targeted therapy is expensive. Study was done, Nigeria, Ghana, and Kenya. And it was discovered that in Nigeria and in Ghana, about 78% of patients pay out of pocket. It was only in Kenya that only 30% of their patients pay out of pocket. It's expensive. It's a pay out of pocket phenomenon. Our patients don't have the money. So one of the challenges, even when you have been able to convince a patient that there's a solution to this problem and he has accepted your options of treatment, he does not have the money. Another problem is access to healthcare. In Ilorin here, many people came for management of breast cancer from rural areas that take them 6 hours on the road. Because outside of Ilorin, they don't have access to it. So by the time some of them come, the clinic would have been over. So many places in Sub-Saharan Africa have very low access to healthcare. And that is a challenge. Another big problem is a weak health system in Sub-Saharan Africa. Instruments needed for management of breast cancer are not readily available. In developed countries, when a patient presents with breast cancer, within 24 hours, you have your tissue diagnosis, you have your imaging done. But in most centers in Sub-Saharan Africa, when you take a tissue for diagnosis today, in some places it takes 3 weeks, some places it takes 3 months, Some places it takes 6 months. And as a rule, all over the world, you cannot treat breast cancer without having a tissue diagnosis. So while you are waiting for 6 months, cancer is not waiting. So that even a cancer that presents early, by the time you are commencing your treatment, cancer would have become an advanced cancer. Radiotherapy in Nigeria, estimated to be of about 200 million population. There are 13 radiotherapy machines in Nigeria, spread over 7 states, with Lagos having the highest number. According to International Atomic Agency, every community of population with population of 250 persons should have a radiotherapy there. So Nigeria needs a minimum of 800 radiotherapy machines. But we have 13. Sometimes all of them will be non-functional. None will be functional. Sometimes 3. When World Cancer Day was celebrated this year, it's only 3 machines that were functional in Nigeria. Africa, there are about 160 radiotherapy machines. 60% of those 160 are in Egypt, Morocco, and South Africa. There are 29 countries in Sub-Saharan Africa that does not have radiotherapy machine. So the instrument for management of breast cancer are not available. Targeted therapy. They commonly use targeted therapy for breast cancer here and even all over the world is trastuzumab. A single dose of trastuzumab is about 400,000, and the patient will need a course every 3 weeks for 1 year. That's about 17 or 18 courses, which an average Nigerian cannot afford. And even when they are ready to pay for, we are not even sure of the integrity of this drug. One of my consultants went to buy a drug, and this drug was supposed to be kept below 8 degrees. So perpetually should be kept in a fridge or freezer. So he got there, he asked for the drug. 400,000, 350,000 naira. Only for the person to go to the counter, pick it, and give it to him. He said, but this drug is supposed to be stored in the fridge. He said, okay, sorry. He now went and dropped it in the fridge and brought another one. So even the ones that are available, the integrity are not known. We are not sure. So most of the instruments we need for the management of breast cancer, they are not available. And that is a big challenge for us in the management of breast cancer in Sub-Saharan Africa. So what do? Even though we have these peculiarities, the challenges are here with us. At least I still remember 1, 2, 3, 4 times that I met patients in the clinic that were managed for breast cancer 30 years ago, 20 years ago in our center here, and they are still alive. So in the face of challenges, we are still making efforts. So one of the things we live here to do is to create more awareness. But the awareness this time around should go beyond you have breast cancer, you don't have breast cancer. We should also make them aware of the need for them to get treated and accept treatment that is available. So again, I say, if you are a woman and after this discussion, you check your breasts, you tell your mother, you tell your sister, you tell your daughters, then you are creating awareness. Number 2, screening. The United States in the last 30 years has reduced mortality from breast cancer by 45%, meaning that they have averted or prevented about 500,000 deaths from breast cancer. And the key instrument in reversing this trend in the United States is screening. And it does not require too much. Younger than 40, go for ultrasound. Ultrasound is about 5,000 Nigerian naira. If you are 50 or above 40, go for mammo. Mammo is about 10,000 naira. So it has been shown that mammography reduces mortality from breast cancer by about 40%. So let us tell people to go and screen. But again, when you are telling them to go and screen, the challenges are also on the ground. A man came to us, say, I will sponsor screening for breast cancer. And we say, it's okay. That is those of us who are young in the profession. But the professor in charge of the unit say no. Say, it won't be correct for him to screen a woman and tell her you have breast cancer, and she will not have a means of having treatment. But there are many Nigerians who can afford the treatment. So we must go and screen. According to American Society of Cancer or Breast Cancer, it is recommended that the general population from the age of 50, because I told us that in the US, most of their cancers occur above the age of 50. A woman who does not have any symptom and who does not have serious risk should go for mammography at least once in 2 years for the next 10 years. A woman with strong risk, somebody whose mother or sister, any first-degree relation has breast cancer, or somebody who carries a mutated gene, should screen 10 years younger than the normal population. So if the normal population screens from the age of 50, the person that has a first-degree relation with breast cancer should begin to screen from the age of 40. And they are not too much for us. We must emphasize on screening. The people that did it in developed countries, they have results to show. Number 3, advocacy. We must take the war to everywhere. We did a study in our hospital here and discovered that about 86% of our patients have a strong trust in their clergies. They trust their pastors, they trust their imams. That when their pastor tells them, do this, they do it. So if we will take this advocacy to churches and to mosques, we are going to have a lot of results achieved. Apart from practicing medicine, sometimes I take time off to go on invitation to preach. Anywhere I go to preach Bible, the first 15 minutes, I always use it to talk about breast cancer. If we are able to convince our clergies in the Sub-Saharan Africa, we are going to achieve a lot in terms of making our people accept treatment and avoid some of the sociocultural factors that are affecting the management of breast cancer. Those of you in power, those of you who have connection, let's take our advocacies to non-governmental organizations. Let's take our advocacies to policymakers. The government must be aware. In conclusion, breast cancer has come to stay with us. It is no longer a disease of the developed nations. Breast cancer is here with high incidence in Sub-Saharan Africa. The mortality from breast cancer in Sub-Saharan Africa is unacceptably high. And that weak health system, poverty, and socio-cultural factors in Sub-Saharan Africa are posing great problems to successful fight against breast cancer. However, if you and I will join hands together in this war against breast cancer, it is possible for us to reverse the mortality trend in Sub-Saharan Africa. Thank you.
Thank you so very much, sir. Honestly, I don't know where to start from. I thought I knew a little about breast cancer. And I know there's going to be time for the vote of thanks, but on behalf of everyone around the call, I want to thank you so much for taking our time to speak to us today, to educate us today. I also want to thank you for doing the job that you do. I thank you so much, sir. On behalf of the women in my life, my daughters, my mom, and my sisters, and my sisters-in-law, everyone that is a woman in my life, my good female friends, thank you so much, sir, for what you're doing.
Thank you.
Your presentation is very simple. You've made it so simple for the people not in medical sector to understand, and the passion behind your lecture, I could hear in your voice a plea, and I thank you so much, even for the way you have concluded. Your message to those, to policymakers, your message to the clerics, your message even to us as individuals, to love ourselves enough to gift ourselves, the screening at the early stage if we discover anything. I'm going to let you take a cup of water, sir. Thank you so much. We will come back to you. There are so many questions, and I know how busy you are. When we were doing the test yesterday, one of the trustees who brought you on board, who invited you, said you're also busy, in the church. So you're busy, in the hospital, in the church, you're a family man, you're a father, you're a husband, and you still set out time to do this for us and with us. Thank you so much, sir. I would come back to you shortly with questions. At this stage, I want to thank everyone around the call. I want to especially appreciate our trustees. We have one of our trustees joining us from the United States of America. Thank you, sir, for joining us. We also have two of them joining us from Australia. Thank you so much, sir and ma, for joining us. I want to recognize a friend of the foundation, a friend of one of the trustees. I want to recognize Vice Admiral Usman Jibri, the former Chief of Naval Staff. Thank you so much, sir, for taking our time to join us. Everyone who joined us is important. Everyone, the teachers that we're doing this for, we honor you, we celebrate you, and we do hope that this lecture today would extend, lives of teachers, male and female, and of people around the call as well. Mr. Egera Edison, are you ready to launch the poll, or do we go straight to the question and answer?
I'm ready to do that now.
Okay, please go ahead.
Okay, the poll is up. We can just take a few minutes to quickly answer the questions. Thank you so much. It will pop up on your screen. Just thank you. Yes, keep them coming. Keep them coming. We'll just do this for another 2 minutes. If you have questions, please use the Q&A box as well. We won't be able to take your questions from the chat box. Please drop your questions on the Q&A box. Thank you. We're almost there. We're almost there. More than
Okay, Edison, the poll can go on because we have quite a number of questions. You leave it on.
You can proceed.
Okay, let me proceed with the questions. Okay, sir, I thank you again. The first question, because we're doing this for teachers and people working in the education sector, we want you to explain to us, can breast cancer affect men? Because we have male teachers, we have female teachers. Can breast cancer affect men?
Should I answer?
Yes, please.
Oh, okay. Thank you very much. Breast cancer also affects men. But in most regions of the world, less than 1% of breast cancer occurs in men. Of all the literatures I look for, it was only in Ethiopia, only one study that shows that it occurs in about 16% of that 16% of breast cancer women. That is what you can have in the whole world. But in most cases, both developed and developing nations, it affects men, but only 1% or less than 1% of breast cancer occurs in men. And the management is the same. The way you manage breast cancer in a woman is the same way you manage breast cancer in a man, except that the man does not have a big breast that will make allowance for breast conserving surgery. I don't know whether...
Yeah, you answered us, sir. That's very straightforward and clear. Thank you, sir. There's another question from Adejo Egbunu. He says, thank you for today's session, sir. After removing the affected breast, does this mean that the patient won't have breast cancer again?
Except that I jump over the risk factors. The fact that a patient has had breast cancer doubles her risk of developing breast cancer in the contralateral breast as compared to the general population. So a personal history of breast cancer is a risk factor for another breast cancer. So the patient that was treated and cured for breast cancer on the left has a higher risk of developing breast cancer on the right than the general population.
Are you done, sir?
Yes.
Okay, thank you very much, sir. Quick one. Kainde Aronsiola is asking what the difference between breast lumps and cancer is.
Sorry, can you come again?
Kainde Aronsiola says, what is the difference between breast lumps and cancer? Maybe to clarify, are all breast lumps cancerous?
Breast lump is used for both malignant and benign diseases of the breast. In fact, the benign lumps are even more in number than cancer. So not all lumps are cancer of the breast. In most cases, when a lump occurs in a patient between the age of 16 and 25, until proven otherwise, it's a benign one. And the commonest among the benign lumps is fibroadenoma. It is not cancer and it's not likely to become cancer. So while breast cancers are breast lump, not all breast lumps are breast cancer. But of all the diseases of the breast, the most dreaded disease of the breast is breast cancer.
Thank you very much, sir. And going by the lecture that you gave us, any identification or citing of breast lumps must not be taken for granted. The person should seek attention immediately and at least be sure that it's not cancerous. You gave us that warning in your teaching earlier on.
Sure.
Thank you, sir. So many questions here, but I'm trying to prune them and help you out because some of them are questions for the attention of government. And you're the face that everybody is seeing today. So the questions are mostly about policy and governance, but we'll take the medical questions. And if we have time, we'll discuss the other issues. Thank you so much, Mr. Olufemi Ransom Kuti. Thank you for joining us and for this very interesting question. The question, sir, is can treatment of breast cancer or any form of cancer be included in health insurance schemes? Do we have health insurance schemes that cover, illnesses like this?
Now, one of the things that we have been advocating for is to make the treatment of breast cancer free or included in NHIS in Nigeria. In the recent time, I think it should be going to 2 years now, close to 2 years or more than 1 year, just about 1 to 2 years. The federal government of Nigeria has included some chemotherapeutic drugs, some, not all, in NHIS. But like one of the articles I quoted for when I was talking, the researcher assessed payment for the treatment of breast cancer in Nigeria, in Ghana, in Kenya. Most Nigerians and Ghanaians pay out of pocket, while only 30% of Kenyans pay out of pocket. That means it is likely that in that country, it is included in their health insurance. Yeah. But in Nigeria, recently, some of the chemotherapeutic drugs have been included, but not all.
Thank you, sir. There's a question, and well, I do know that some people go for diet.
Yes.
To help, they say they're treating cancer by certain diets. Sharifa Raji Afolabi says, what is the role of diet in breast cancer prevention and treatment?
Now, thank you, ma. Except that I just glossed through the risk factors. Yeah. One of the risks is diet. Studies have shown all over the world that diets that are rich fruits and vegetables, they significantly reduce the risk of developing breast cancer. So diets that can prevent, emphasize on fruits and vegetables. But there are some conflicting studies. Some diets, high saturated fats can increase the chances of breast cancer, but they are not well established. Now, for the treatment, that is prevention. For the treatment, especially in Nigeria, where I practice, our patients come with different food supplements. Some from China, some from this, some from this. I do not come across any study that show or prove that they work or cure. But I have seen so many of my patients who came, decline our options of management, which is cheaper than some of these food supplements. But they later come back. Many of them, they later came back with advanced breast cancer. I cannot remember which of the food supplements they use, but there is no proven study that shows that any of those food or food supplements cure cancer. But I know that there are a lot of things on the internet, come for natural cure, come for all of this. People must sell and get their money, but we don't have any proof that
no statistics to support that. Yeah. Thank you so much, sir. And pardon me if I'm rushing it, because I want you to answer as many questions as possible. There's this, it's from someone who is anonymous, and it's a very good question. He or she says, for someone who has had breast lump and had it removed immediately, what's the probability of the person having breast cancer? And what would you advise the person, what care would you advise the person to take in terms of screening subsequent to this?
As a rule, and it's all over the world, any lump excised or removed must have a histologic diagnosis. And like I have said before, breast lumps that are not cancerous are more in number than breast cancer. Like fibroadenoma, the commonest one. If you remove it, you look at it under microscope, histologically it is benign. Go and sleep. It can recur. If it recurs again, remove it. If you remove it, make sure histology is done. If it is benign, go and sleep. Unfortunately, one of the challenges we also have in this part of the world that even make us query our level of education, whether education has helped us the way it should have helped us is, even some doctors will remove breast lump. They won't take it for histology. And so the patient will come after 1 year and say, doctor, help me to remove it. We say, where is the histology? They say, we buried it. Now, in fact, we are taking campaign to private practitioners that if you are afraid that patient will not pay for histology, include the cost of histology in the surgery. That's so right. That by the time he pays you as if he pays for surgery, take the money for histology and go and get the histology. Once it comes out to be cancer, refer that person to a specialist. Yeah. So it's very common in Nigeria that they will remove breast lump, they will throw it away or they will bury it, not knowing that that lump is carrying cancer and it will recur.
Yeah. Thank you very much, sir. And thank you for, to the anonymous person, because that's a very big lesson that my team and I will, put on, social media when we're educating people after this workshop. Histology is very important. And if you're giving yourself a gift of removing a lump early, you should insist and tell your doctor that you want the histology done to be sure that you're completely free of cancer. I don't want to make assumptions here, sir. Just a quick one. Can you explain the difference between malignancy and being benign, just for people who don't understand it?
Malignancy means cancer. Benign means non-cancer. One of the key characteristics of benign is the fact that it is localized to the breast. maybe it will not be an overstatement if I say benign does not kill. But cancer does not, because see, the cancer, the cause of cancer is normal cell that transform. It just decided not to obey the natural rule of cell growth. Because every cells grow. But when it gets to the limit, it stops there by check and balance system of the body. But malignant cell does not obey. It will keep growing, to keep growing, to keep growing. Not only that it's growing in the breast, it can also send secondary cells to different parts of the body. That is actually what kill patients. So the key difference between malignant or cancer and benign is the fact that the benign does not kill. So to say, the benign will always be localized to the breast. Meanwhile, cancer kills. Cancer can go beyond the breast to the brain, to the lung, to the bone, to the liver, even to other parts of the body.
Yeah. Thank you very much, sir. And I want to thank everybody who has been bold enough to ask us questions. Some people are asking us these questions because of the people in their lives or because of things they have read online. My next question to you, sir, and because, you know, the foundation, the Rehoboth Dream Solid Foundation caters for young people, young adults. And I do know that a number of young people are around the call. And the teachers that we're celebrating this month, they deal with young people. So this next question is very important. And I do thank Adeyemi Mojid for the boldness to ask this question. Now, his question is, you answer it the way you want to answer it, sir, but he says, what is the implication of sucking the breast of a lady with breast cancer?
Well, breast cancer is not contagious. And I have not come across any documentation that because a breast cell or a cancer cell is sucked and swallowed, it now get implanted somewhere and now grow into cancer. I have not come across that. You know, one of the risk factors for breast cancer is non or inadequate breastfeeding. In fact, one of the reasons why it was not common in our grandmothers or great-grandmothers was the fact that they breastfed and breastfed and breastfed. That some scholars believe, though it is not proven, but some scholars believe that the breast, the cells that will misbehave, even early in life, they are already there in the breasts. That as babies suck, the chances that babies will suck some of them out is the reason for the reduction in risk of developing breast cancer in women that breastfed children. So I have not come across where it is documented that by sucking a breast with a cancer is going to give you a cancer, maybe in the stomach or anywhere. Even women with breast cancer, they breastfeed their children, even from that breast. So if it causes breast cancer, that means automatically that baby should carry cancer from the mother. Okay. It's not documented anywhere. In fact, let me say it does not.
Yeah, thank you, sir. Thank you, sir. I have a question from Abisola Lakoja, who joined us pretty early, and I think is one of the teachers we're celebrating in this period. Please, sir, how frequently should screening be done if there is a cancer? And should it be done only when a lump or discharge is noticed? Now, that's a question from Abisola Lakoja. In addition to that, sir, I want you to explain the frequency of the mammograms for the age brackets so that people around the call, because I was told that after 50, we should do it annually. Maybe you want to give us explanation of the age brackets and when to do it, and then perhaps address Abisola's question.
Thank you. And let me use this opportunity to also explain this. For people who are young, they have high density breast tissue. Mammogram will not pick any lesion there easily. So for the young, ultrasound is good. In fact, in this part of the world, we set 40 for those who will go for ultrasound and above 40 for mammo. But there is even a dispute, even in the US, whether mammo should be done between 40 and 50. But radiologists have claimed that, especially at that age bracket, between 40 and 50, if you combine mammo and ultrasound, the sensitivity is much higher than the single imaging. So within that age bracket, some radiologists advise that do mammo and ultrasound together. But below 40, mammo may not give you any good result. Ultrasound is the investigation of choice. Above 50, mammo is the investigation of choice. Now, there are many guidelines. I mentioned the American Cancer Society. They recommend that those who don't have strong risk, apart from the fact that you are a woman, you are 50, which is a risk that you cannot avoid, the general population should have mammo once in 2 years. WHO says once in a year. I think the US is considering maybe NHIS, the costs, but guidelines differ from one place to another. But most of the guidelines fall within 1 to 2 years. But for a patient that we have treated for breast cancer, it doesn't follow that. When we finish our treatment, he would do an imaging, either ultrasound or mammo, depending on her age. The following, in 6 months' time, he will repeat a mammo. Then he will do it once every year for the next 5 years before we change it to once in 2 years. That is our own local guideline here. I don't know whether I've answered that question.
Yes, sir, you have very well. And I want to encourage everyone who is a part of this to re-listen, to go back and listen to the recording of this session. We would have it on our YouTube channel, soon, maybe today, latest tomorrow, so that we'll share the link with everybody who registered, so you can share this session with people in your life. There are so many nuggets, so many, I thought I knew a little bit about it, but my knowledge has been enhanced. So we may not be able to take in everything as we're listening, but you need to revisit this, and women, men need to also revisit and listen to this. Thank you so much, sir. I must tell you that all the while we've been doing webinars, I'm not sure that I've had the amount of questions, the number of questions that I'm receiving today, and I'm trying to do my best to get to as many of them as possible. Thank you, Pastor Mrs. Atinuke, Pastor Dr. Mrs. Atinuke Richard. I'm going to take your question. I'm partial, yes. My pastor's wife, and she's a doctor too. Now, sir, she says, what's the sensitivity of mammography in breast cancer detection? Are there other sensitive investigation methods?
The sensitivity of mammo, like I said at the time, is dependent on the age. It's more sensitive in a woman that is above 60 than a woman that is just above 40. The sensitivity of mammo is between, I think, maybe 56 to 70 something. But when combined with ultrasound, it increases to about 90%. Now, the instrument for screening is mammo or ultrasound, depending on the age. Or sometimes the mammo or the ultrasound does not give a conclusive report. It becomes an indication for higher imaging, because when MRI, magnetic resonance imaging, comes in, the sensitivity is even higher in detecting lesions that mammo does not pick. But it is not, even all over the world, it is not the instrument for screening. It is only a second line investigation or screening instrument, when the first line instrument do not give you a definitive answer, or the first line comes out to be normal and the patient said, I have something. You see, I feel something is pricking me there, but he has the imaging. The imaging say normal. I have seen a patient, in fact, I have seen 3 patients like that in the last 2 years. One was a member of my church, and eventually she came out to be cancer of the breast. He complained to me. I said, go and do mammo. He did mammo. Mammo came. Mammo said, normal. I said, oh yeah, go and do, it's 50 years. Go and do ultrasound. Let's put the two together. But make sure it's the same doctor that reported the mammo that will do the scan for you. I called the doctor. I just felt, come, let me examine the place. But inside, I felt that something was there, small. I said, don't you think something is here? He said he too was not sure. I said, come, follow me. I took her to the clinic. I biopsied the place. It came out to be malignant. But mammo say normal. So where a patient imaging say is normal, and the patient has a complaint, is now an indication for a higher imaging. MRI, CT scan, or some other higher ones are not the first line for screening. Is that clear, Clemma?
Very clear, and a little bit scary, but won't be scared, because I hear you saying that sometimes mammogram may be, may not detect it. Yes. But a combination of imaging and maybe other higher level investigations, if the patient continues to say, I'm feeling something. Yes. Yeah, it's clear to me. Thank you very much. And I'm sure that Dr. Mrs. Richard is also clear. But I can always connect both of you because you're both pastors and doctors. John Felix is already, he has sent his question like 3 times saying that I must answer it. So I have to read his question. But I was just trying to take some more of the medical ones before his. But he says, there are conspiracy theories going around that due to the harsh weather in Africa, diseases like COVID and cancer have little or no chance at all. And he says he's been falling for that myth. He wants to know how true it is that diseases like COVID and cancer have no place in Africa.
Okay, that diseases like COVID and cancer have no place in Africa. Ah, that's serious.
The answer is in the question, but he's come up that I don't want to put this question out there. I think, well, do you want to answer it, sir? Because your session earlier on already told us that, these things are real.
Every clinic day in the University of Ilorin Teaching Hospital, we diagnose cases of cancer. And I have not seen a white man or woman in my clinic before. In 2018, our cancer registry recorded 84 new cases. In 2019, it recorded 96 new cases. In 2020, because of the COVID crisis, the registry was shut down and many cancer patients were not attended to. We recorded 70. In 2021, we recorded 202. In 2022, our registry, this single hospital recorded 135. All of them Africans, all of them Nigerians. We are, who say cancer does not, I'm not a specialist in, I don't know much about COVID, though. But I know that COVID kills some people in Nigeria. But for cancer, I have certified people killed by cancer. I have managed people with cancer. So cancer has place in Africa.
Thank you, sir. I only asked that question because I want you to re-emphasize what you've been teaching us earlier on. I mean, the whole session and your presentation has all, the evidence is there that, cancer is in Africa. Quickly, sir, this is very important because I think two people asked the question and, well, it's anonymous, but the person says, can dirty underwears, dirty bras, can dirty underwears cause breast cancer? And sir, can I add mine to that? Can deodorants, we've been told that we shouldn't use deodorants with aluminum and some other chemicals, that deodorants and deodorants cause cancer. So their question is about dirty underwears. My question is about deodorants.
Hey. It's dirty underwear. It's just a public health. I have not come across where that causes cancer. But I want us to also know that some cancers are also linked with infections. Breast cancer is even now linked with HIV. So if dirty underwears can cause an infection that may result in cancer, but for breasts, in fact, I read one article yesterday about use of bra, whether dirty or clean. And studies have shown that use of bra is not associated with breast cancer. Well, the deodorant, I don't know what is the content of it. But we know that heavy metals are notorious for kidney damage and for causing cancer. But I have not come across articles where it is documented that deodorant causes breast cancer. I have not come across it. Okay, sir.
Thank you very much, sir. My timekeepers are saying to me that I have very little time left. There's a question from, well, the person is anonymous. You say you teach in a school that has all girls, and you're asking if there is a center where young people can access help. She says one of her students has lumps. One of the teachers around the call works in a school for girls and is asking if there's a center where young people can get help. And there are other questions where people are asking what this foundation can do for in terms of support for people who have health problems. What I would say before Dr. Onjefu answers is that the Rehoboth Foundation does not deal with health, but we can guide you to foundations who support healthcare. we know a number of foundations who can help. And to those who have asked a question around policy or who have put it forward, asking what the government is doing about what all that Dr. Onjefu has spoken about, we are all the government. Whatever we can do in our places of areas of influence to speak to people that we know who have influence and who can speak to government, please do. You also have a responsibility to make sure that you put the right people in government. So these are the reasons why we all have to do things correctly. Now I would come back to Dr. Onjefu for the last question.
That whether I know where young ones
can access, is there any center, any foundation, any group of people who are giving back that you know of who can support?
Honestly, I don't know.
Yes, sir. There are some other questions. Like I told you, I have 50 open questions. So what we're going to do is my team and I will look at these questions and we would revert to you, sir, and get responses from you. For those who ask the questions anonymously, you can send us an email, rehobothDream@gmail.com, and so that we can get your answers back to you. But for those who identify themselves, once we get the responses from Dr. Onjefu, we will share them with you, and I think even share with everyone who registered for this webinar. I can't thank you enough, sir. And I know I'm not supposed to give the vote of thanks, and I'm going to yield the mic to the trustee that will give the vote of thanks. But I want to thank you for what you're doing. I want to thank you for staying in Ilorin. I want to thank you for the research you're doing. I want to thank you again for the past articles that you've written for the magazine. And before I ask the trustee to give the vote of thanks, I want to also thank him for choosing this topic and for engaging you to come to speak to us today. On behalf of everyone around the call, on behalf of all the women in my life, I say thank you, sir. Thank you so very much. Thank you,
ma.
Thank you, sir.
Yes, thank you so much, Dr. Onjefu, Stephen. I am K.O. Komolafe, Rear Admiral retired. I want to say that I thought I knew you, but you have proven me wrong this morning. I saw Stephen that has passion, that is compassionate and committed to what he's doing. I also saw Stephen that is committed, among several other things that I saw as I was watching you. You are so committed to what you are doing, and you are so knowledgeable. I must have been underrating your capacity in these areas. I apologize for this. I'm glad you are my friend. I want to publicly declare that you are my friend, and I'm so glad that you are my friend. And I want to thank Ofiku Jonathan Onjefu, Lieutenant Commander, your senior brother, through whom I met you. And since then, we have remained friends. I want to thank Jonathan for letting me know you, or for letting me meet with you. Thank you so much for a very brilliant lecture. To say that it is highly educative is an understatement. We are going better informed on the subject matter than we came. Thank you also, like Mrs. Komolafe said, for your contribution in articles to the magazines. I think, if I can recall very well, you have written more than 5 articles for our quarterly magazine. I will continue to pester you to even write more. We are encouraged. We encourage you not to relent in your advocacy. You know, it is God that has given you the knowledge. continuing to do this, and I pray that God reward you himself. So once again, thank you so much for honoring this invitation and for all that you did to make it possible. I know that the month of November has been a very busy month for you. And I also know that that you came from a program to this program, and you are also going to another program from here. You actually initially pleaded with me that I should take away the month of November. I said, no, it cannot change. But you squeezed the time to be present here. So I hope when we call on you again, I'm sure we will, you will respond positively. Dr. S.A. Onjefu, thank you so much. We really do appreciate you. Thank you.
Thank you, sir.
Thank you.
Thank you, Admiral Komalafe. Thank you so much. That's one of our trustees and the co-founder of this foundation. I want to thank again Vice Admiral Usman Jibril for staying with us to the end. I want to thank every sponsor, all our financial sponsors around the call, those who send in their little contributions. Our slogan is little drops, big changes. Thank you so much for all the support. Thank you to Pastor and Mrs. Opadia, our trustees in Australia. Thank you to pharmacist Samson Igokwe, our trustee in America. On behalf of the chairman, I thank everyone around the call. I think Edison is going to explain to us now some modalities around the prize, because there are questions in the chat box, Edison, around who and how you select the winner. Thank you so much again, sir. God bless you, and God bless your family. Thank you so much, sir. Thank you. Thank you.
Thank you so much, sir, Dr. Onjefu. Thank you, sir, for coming to do this for us. We really appreciate you. This webinar is in honor of teachers. The award ceremony itself will be holding on Thursday, and I'll be communicating directly to the nominees. So thank you so much, sir, once again, and God bless you. Now, to everyone that has joined us from various regions, I want to say to you that for your question about the referral, all you need to do is after this meeting, you are going to get an email. In that email, you will find a link, a survey link. Just fill it, and that is all. You can fill the person's phone number as the phone number of the person that referred you, and that's it. That's all you need to do. It's very short. It's about 3 questions there, and that will be all. So thank you all. Thank you. God bless you all. I can see a lot of us who are beneficiaries of the foundation as well. I want to say thank you all for coming. We look forward to having you guys again at our next webinar that will be coming up within the first quarter of 2024. Thank you, and God bless you. Thank you to all those that are sponsoring us. Thank you to all those that have been participating in our other events. God bless everyone. I think that will be all from us. We see the teachers on Thursday. I'm going to communicate directly to you all, and thank you. God bless you all. Have a nice day.
Thank you, Edison. Thank you to you and the team, and to all the volunteers around the call. So you have to thank yourself too. Well done. Good job. Very, very good job. Thank you, Grace. Thank you, Dorcas. Thank you, Edison, and all the volunteers. Thank you so, so much.
Thank you, ma'am.